ahead and why is it not moving? Yes. So what I'm going to talk is a couple of slides about anatomy physiology, but don't get very upset. It will not be true anatomy physiology, but more of a applications of this onto peritoneal dialysis. And then obviously, you know, the goal of dialysis, any dialysis, and also of peritoneal dialysis is solute removal and ultrafiltration. So we'll talk some basics about both of these topics. And then one very important questions which comes to our mind when we study or when we practice PD is that why there is difference in ultrafiltration between glucose, icodextrin, and all this. So these three basic topics I would like to cover today, and let's see what is the feedback subsequently. So regarding anatomy of peritoneum, you know the peritoneum is the lining of abdominal cavity, and it has two layers, parietal and visceral. Parietal part is the one which covers the inside of the abdominal wall and the undersurface of the diaphragm, and the visceral part is those which covers the entire organ system within the abdominal cavity. So parietal peritoneum contributes to only 20% of surface area of peritoneum. So you should know that. And then 80% of the surface area is by the visceral peritoneum. And if you see the surface area, total surface area is almost equal to the body surface area, which is about 1.5 to 2 meters square. It is a very highly vascular organ, I would say. And it is semi-permeable, which is the requirement of for dialysis, as you know. So it's a synthetic, it's not a synthetic membrane, it's a God-given membrane as compared to the dialyzer membranes, which we use for hemodialysis. Apart from this, you should also know that there is lymphatic drainage of the peritoneal fluid back into the system as well. And this predominantly occurs through diaphragmatic stomata. And you should also know that this peritoneum is in continuum with fallopian tubes in females, and that is why sometime or occasionally you see in menstruating aged females doing peritoneal dialysis, there might be hemoperitoneum or hemorrhagic PD effluent. So one of the cause for hemorrhagic PD effluent may be menstrual cycle apart from several others. So you should know this as well. Now, we discussed that there are two important components of dialysis, solute removal and fluid removal. Solute removal predominantly in peritoneal dialysis occurs through diffusion. And diffusion, we all know, and I'm sure you know, is movement of solute from higher concentration to lower concentration. However, fluid removal in peritoneal dialysis, and this mechanism doesn't operate in hemodialysis, is all by osmosis. So osmosis means movement of fluid from lower concentration to higher concentration. Okay. So this is just a breather for me. I'm sure you know CAPD and APD. So CAPD is continuous ambulatory peritoneal dialysis, which in India we do 3 to 4 times the conventional part. I'm not talking about incremental right now. So conventional people do 3 times in a day or 4 times in a day. And the longest dwell period is the night time, where they keep the fluid in the belly for about 8 to 10 hours, or maybe sometimes longer as well. And in automated peritoneal dialysis, all the short exchanges are done during night time, which is done by the automated machine. And during daytime, they may have last fill as a longest dwell, which may last from 12 to 14 hours or even longer, right? So now coming to a very important part of our, after the introduction, very important part of discussion is the models of peritoneal transport. So there are different models which has been, some of them have been hypothesized, some of them have evidence, but these are few important models which you should know of, because it helps in understanding the mechanism of transfer of solute and fluids as well. Out of these 3 models, which is called the 3-pore model and the pore matrix model and the distributed model, the 3-pore model is most popular. So let us discuss this first. So according to these 3-pore models, there are 3 different kinds of pores in the peritoneum. And they are named as large pores, small pores, and ultra small pores. Now, large pores are few in number. That means it represents only 3% of total surface area. And as the name suggests, the pores are larger, and hence it allows macromolecules even albumin to cross over from the vessels into the peritoneal cavity. And actually, they are believed to be clefts within the endothelial cells. So that these are some properties of large pores. Size is also mentioned, it's large, 100 to 200 angstroms. The small pores again is also hypothesized as a clefts in endothelial cells, but the pores are smaller in dimensions, only 40 to 60 angstroms in size. But these are the predominant pores in the peritoneum as far as the dialysis is concerned. So 95% of surface area of the peritoneum is embedded and covered with small pores. And it allows both solute and water predominantly to transport from one side to the other side. And the third one, as I mentioned, is the ultra small pores, which are very small, measuring only 4 to 6 angstroms. And actually, they are aquaporin channels. And why this is important, as I said, we'll be talking about clinical application as well. Now, when you talk about ultra small pores, the aquaporin one, you know that this only transfers water and it has nothing to do, no business in transporting the solutes. And because it only transfers water, there is a terminology which you might be aware is called sodium sieving. Now, what is sodium sieving? This is a question many times people ask when they talk about peritoneal dialysis. And what solution causes sodium sieving out of different solutions which are available? So what sodium sieving actually is, let me explain this with this diagram. So what happens is when glucose is instilled into the peritoneal cavity, because of the osmolality, these aquaporin channels are stimulated. And what happens is when they are stimulated, it allows transfer of significant amount of water into the peritoneal cavity. And what happens if water gushes out into the peritoneal cavity? The sodium level which is present in the dialysate, mark it, right now I'm talking about dialysate. The sodium level which is present in the dialysate gets diluted with this water, and the sodium level concentration goes down in the peritoneal fluid. On the contrary, what happens in the blood? Since the water leaves the blood compartment, there might be transient hypernatremia in the blood. And as the PD process goes on, it is equilibrated because the small pores gets activated and salt and solutes and all these things start coming into the peritoneal cavity. I hope you understand this part. This is very important. And all these transfer, the gush of fluid from the aquaporin occurs in first hour. So when you instill 2.5% dextrose, in 1 hour, the sodium concentration in dialysate is minimum. And as you can see, this yellow line represents 2.5%. At 60 minutes, sodium level goes down, the minimum. And gradually, as small pore starts working, again the sodium level goes up and it may come up to the previous levels. When you use a higher concentration, 4.25, the minimum sodium concentration may achieve between 30 to 60 minutes and can prolong up to 90 minutes as well. And then gradually again picks up. So what do you mean by sieve? Sieve is chalni, you all know. So what happens is the water comes down, the sodium or the solute part, which is slightly bigger molecule, remains into the blood. And what results because of this sodium sieving is transient hypernatremia and I should not say hyponatremia, but decrease in sodium concentration in dialysate fluid. What is the clinical application of this? So if you document that first hour sodium level goes down in the dialysate fluid, that means the aquaporin channels are active. They are working, right? In long-standing diabetes because of sclerosis or fibrosis or because of repeated peritonitis, the aquaporin channels may get destroyed over a period of time. And there might be poor ultrafiltration, and this simple test can document that there is failure of ultrafiltration because of aquaporin channels getting disrupted or not working. Right? I hope that this part is clear to all of you. Sodium sieving, what is the concept and what is its application? So let's move to this further second part. So I told you about 3-pore model. There are 2 other models which are less popular, but for theory purposes, you should know this. One is pore matrix model. Here also there are 3 different pores. but the explanation is a little different. So aquaporin is here also, which is concerned only with water transport. And there are two different kinds of pores, but they are lined with glycocalyx. Now, glycocalyx, whether it results in pore allowing macromolecules to transfer or smaller pore which allows only smaller solutes to transfer, depends upon the density of the glycocalyx. If the density of glycocalyx over the membrane is dense, very huge, high, then probably the pore size will be smaller, only working for smaller solutes. So predominantly, again, it is small pore and large pore only, but the explanation is it depends upon the density of the glycocalyx, and it may be variable as well. Today, it may work as a large pore, and there are factors which can induce density of glycocalyx, and it can work as a small pore tomorrow. So this is about the other model. So as I said, the small and large pores represent different functional states of single entity. It's a single entity that depends on the density of the glycocalyx. And the third model is the distributed model. So what does distributed model tell? And it's predominantly for ultrafiltration, not for solute transfer. So there is cell extracellular matrix. This is the peritoneal cavity. This is the peritoneal membrane. So peritoneal membrane, and this is the interstitium, what you say, or extracellular matrix. So there are vessels inside this, capillaries. Now what this model says is when you instill dialysate into the peritoneal cavity, because of presence of glucose, there is an osmotic pressure and there is absorption of dextrose across the membrane into the vessels. So because of the absorption and osmotic effect, there is passage of fluid into the peritoneal cavity. Now this again depends upon the proximity of the vessels as compared to the peritoneal cavity. So farther away from the peritoneal cavity, the effect of peritoneal membrane, the effect of osmotic effect will be lesser. So all those capillaries which are very close to the peritoneal cavity will have a higher impact of osmotic effect. And that is why if you see the arrows are a little thicker here, they will allow the transport of water more briskly, more abundantly as compared to those capillaries which are a little far away from the peritoneal membrane. So this is what is distributed model, and it tells that initially the capillaries will release the solute as well as ultrafiltration into the interstitium, and from the interstitium it will pass into the peritoneal cavity depending upon the proximity of that area to the osmotic agent. So these were three pore models. Some part of it was theoretical, but some were very important to understand the concept of peritoneal dialysis and ultrafiltration, which we will discuss in detail later on as well. So next is, let's see what is next. So coming to the clinical part, as I said, the two important things are solute clearance and fluid removal. So solute clearance, as I said, predominantly occurs through diffusive mechanism, but small part occurs because of convection as well. Now convection, how does convection play a part? So whatever fluid is removed, along with that fluid, it drags some of the solutes. And this physiology happens in hemodialysis as well, which is called solvent drag. So very small solutes, small molecular weight solutes can get dragged with fluid removal, and that also contributes to some part of solute clearance. And now we will discuss individually about solute clearance and fluid removal. Let's talk about solute first. So what are the factors which influence solute removal in peritoneal dialysis? For example, first is surface area. If you recall, in my initial slides, I mentioned that the surface area of peritoneal membrane, is about 1.5 to 2 meters square, which is equal to body surface area. Now, when you put fluid into the abdominal cavity, actually the entire area is not involved in peritoneal transfer. Only 30 to 60% of area is involved in actual transfer. So if anything can increase the area of involvement of the peritoneal membrane, for example, somebody who is falling short of adequacy of peritoneal dialysis, and you want to increase the solute removal. One of the mechanism you must be knowing and might have been discussed in your respective units is to increase the volume. So instead of increasing the number of exchanges, if you increase the volume from 2 liters to 2.5 liters of dialysate volume, right? What will happen? It will include more surface area of the peritoneal membrane and thereby lead to more increase in solute removal. That is one part. Second, how to influence is peritoneal permeability. Now, there are mechanisms by which peritoneal permeability of the vessels may increase. For example, if there is PD peritonitis, there is inflammation, so permeability increases. So solute removal might increase. There might be a caveat that glucose absorption will get hastened and equilibration will achieve faster and ultrafiltration may not occur that much, but permeability can increase the solute clearance. What about the solute characteristics? Third part is solute characteristics. Now you know that every solute has its molecular weight. Those which are smaller molecular weight solutes, for example, urea has molecular weight of 60. It will pass on easily as compared to creatinine, whose molecular weight is 113, almost double, will take a little more longer time. So solute characteristics also determines the solute diffusion. The fourth is concentration gradient. Again, this is very simple that if the concentration gradient for individual solute is high, the transport will be higher. Then there are certain smaller factors which influences, for example, temperature. When you instill in cold or winter time, when you instill a cold dialysate, it induces vasoconstriction. And because of that vasoconstriction in the peritoneal membrane, the solute clearance may get little impaired. Blood flow, as I mentioned in peritoneum, in the peritonitis, or there are certain drugs, for example, calcium channel blockers. It has been shown in studies that calcium channel blockers may increase the blood flow, and though it is a fractional part, but these are factors which you should know can influence the solute diffusion. Overall dialysate volume, so one of the mechanism I said is increase the volume and increase the number of exchanges. So if the volume from 6 liters a day goes into 8 liters, solute clearance will increase. The dwell time, for certain solutes, higher dwell time will be higher, and I'll show this in the next subsequent slide. So if you see this slide, what it shows is the clearance in the y-axis and duration time, dwell time in x-axis. So longer you keep the fluid in the peritoneal cavity, what happens is urea, being a smaller molecule, almost gushes in the first hour, equilibrates at 4 hours, and after that the removal may be either negligible or minuscule. Creatinine, being a little higher molecular weight solute, it takes a little while. So in 4 hours, maybe a substantial amount may be cleared, but till 8 hours, there still may be substantial or significant clearance, after which it equilibrates. What about middle molecules? Middle molecules being a larger molecule, the molecular weight being from 500 to say about 12,000, it takes a longer dwell time to have some effective clearance. So what it says is diffusive flux is highest in the first hour. As I said, it gushes out, and because the gradient is largest and decreases over time. So this is, again, you have to remember this, and this is important. By 4 hours, urea is 90% equilibrated. So you do not expect more urea removal after 4 hours. And creatinine is about 60% equilibrated. So even after 4 hours, 4 to 8 hours, there might be a little more of clearance of creatinine. Further, small solute removal is modest after 4 hours, and long dwells are important for removal of middle molecules. For example, beta-2 microglobulin, which has a higher molecular weight, almost 12,000, right? So this was about factors which influences the solute removal. And based on this solute removal, you should also know that there is a terminology which is called peritoneal equilibration test, which is called PET test. And depending upon this PET test, there are 4 different types of peritoneal membrane, or the behavior of peritoneal membrane. And I'm sure you know, you must have heard this. They are categorized as high transporters, high average, low average, and low. And sometimes we call high average and high as a fast transporter, and low average and low as a slow transporter. A couple of slides about PET test, because sometimes this is important as a short note, and sometimes you are asked in Viva as well. So what we looked into this PET test is dialysate to plasma creatinine at basically 4 hours. So D over P creatinine at 4 hours. And apart from D over P creatinine and urea, we also look at the absorption of glucose. So D over D0. So dialysate glucose at 4 hours divided by dialysate glucose at initiation. So D over D0. And usually the curves I will show you are reciprocal between urea creatinine and glucose, because glucose is getting absorbed and urea and creatinine are coming into the dialysate. So as the time passes, dialysate urea creatinine increases, dialysate glucose goes down, and that is why there is reversibility in the curve. So how you do PET? So in standard PET, what you do is there has to be a night dwell. So supposing somebody is on night drive, what you have to do is for PET test, you have to ask them to put in a 2.5% and keep it overnight. And when they come to the hospital or your clinic where PET test is supposed to be done, you drain it off and put a 2 liters of 2.5% dextrose solution. And while instilling the dialysate solution, you have to ask patient to roll down. I mean, details you can see in the book. Roll over one side to the other side as this goes on. And then what you do is, as soon as the dialysate goes in, you draw a blood and dialysate sample at 0 hours, then at 2 hours, and you drain out the entire fluid at 4 hours and do blood and dialysate test again. So there are three tests at 0 hour, 2 hours, and 4 hours. And then you chart this urea and creatinine based on the hours and D over P, urea, creatinine, and glucose. So this is a curve for urea. So D over P urea over time, and these are the different curves which can be achieved depending upon the DP urea, DP creatinine, and DP glucose, right? So depending upon this, again, these peritoneal membranes are divided into 4 different characteristics. This is usually above 0.8 creatinine is high transporter, then comes high average, then comes the low average, and then comes the low transporter. And they have clinical application, as you know, as you will see subsequently also. Let me go to the other slide and then we can discuss about the applications. So this is glucose, which as you see, this is increasing, this is decreasing. The reversible of creatinine, D over P creatinine. Now, this was a standard peritoneal equilibration test, PET test. Now, there is something called modified PET test. The procedure is same. The only difference is instead of 2.5%, you put in a 4.25% dextrose. You give a larger osmotic gradient. And in this, ultrafiltration is obviously expected to be higher. And what is the clinical application of using 4.25%? Number one application is if the ultrafiltration with 4.25% over 4 hours is less than 400. So 4.25%, 4 hours less than 400. That means the patient can be labeled as ultrafiltration failure. And you have to work out what is the cause of ultrafiltration failure. But for today's discussion, the patient can be labeled as ultrafiltration failure, right? So if you compare between 2.5 and 4.25, the curves are similar. See, DP, this was DP over urea, this is DP over creatinine, and this is DP over D0 glucose. The curve looks exactly similar. And there was a study to look at the concordance between 2.5% and 4.25%. It was relatively concordant. If you see urea, there were 3 discordants. Creatinine, there was only 1 out of 47. And glucose, there were no discordance. So 4.25 can also be used, and it has an advantage that you can label ultrafiltration failure. And if you do sodium levels, you can document functioning of aquaporins as well, right? So 2.5 and 4.25 standard and modified PET. You should remember this. Now the question comes in, when should you do a PET test? So usually we wait for 4 to 6 weeks for peritoneum to get equilibrated once PD is initiated. Then we do the first PET. And actually there is no study which has shown that repeated PET test helps in clinical judgment or clinical management of the patient. However, whenever there is a doubt, especially, for example, after recurrent peritonitis, if the ultrafiltration is going down, or the patient is not doing well, or the monthly lab shows that urea creatinine is going up, in that scenario, probably PET test can be repeated to document that there is change in characteristics. So sometimes because of repeated peritonitis, somebody who was low average or high average can go into high transporter as well. So there you would like to document and accordingly change the PD prescription. We can talk about PD prescription in one class some other time if I got an opportunity. So that is about when to do a PET test. So this was briefly all about solute, factors influencing solute, the PET test and modified PET test, etc., etc. Now coming to the second part, in another 15-20 minutes, I would like to wrap up about the fluids part. So ultrafiltration, now if you see ultrafiltration, where you use a lower osmotic agents like 1.5%, then what happens is dextrose concentration is low, it rapidly gets absorbed into the system, and the osmotic gradient remains either low and gets dissipated or equilibrated. That is why there might be some ultrafiltration, for example, 100 ml in initial hour or two. But if you keep it for longer hours, the ultrafiltration actually can become negative. That means patient will start retaining the fluid. So you put in 2 liters, you may get only 1800, which is called positive or negative ultrafiltration. However, you use 4.25%, which is a high concentration bags, the ultrafiltration keeps going up to 4 hours almost. And then slowly, if you keep it for overnight stay for 8 to 10 hours, the ultrafiltration may come down. So peak from say about 600, it may come down to 400, 300 or 200 depending upon the duration of dwell of the high concentration. And if you keep 7.5%, which is icodextrin, which actually is a glucose polymer, don't confuse, it is not dextrose and it doesn't get absorbed significantly. So what happens is, because the osmotic gradient is continuous, the ultrafiltration though occurs slow, and we will see how it occurs slow, and it keeps going on even up to 10 to 12 hours. So when you require more ultrafiltration, you can use higher concentration bag or icodextrin. But when you use icodextrin, you have to keep in mind that you will have to keep the fluid for longer hours. If you remove it in 4 to 6 hours, you won't get a significant ultrafiltration. This is very important. So sometimes question is asked, if a patient presents in fluid overload and there is no access and you want to continue with peritoneal dialysis, how will you manage? Never say icodextrin, because there you will require small, frequent, high concentration glucose bags to result into maximum ultrafiltration, right? So that was the clinical part. Now, you have to understand that it's not one-way mechanism. There is small amount of fluid which may get absorbed from the peritoneal cavity back into the system as well. It predominantly occurs through lymphatics, but sometimes through the tissues as well. And you should know that absorption can occur at a rate of 1 to 2 mils per minute. That means 60 mils per hour. So at the end of 4 hours, for example, about 240 or 250 mils of fluid may be reabsorbed. So what you are getting as a final ultrafiltration is actually whatever has come into the peritoneal cavity minus what is absorbed. So this is very important. You should remember that there is backflux as well. And what are the factors, like we discussed, factors influencing solute removal? Similarly, there are factors which influences ultrafiltration. Now, surface area and peritoneal membrane permeability we have discussed. Larger surface area involvement, ultrafiltration increase. If the permeability is higher, then ultrafiltration may decrease actually. Initially, there might be gush, but then reabsorption might also be there. Now, apart from these smaller contributors, there is a larger contributor, and please, I request you and suggest you to focus. I'm coming to a little complicated part of understanding of ultrafiltration. So please pay attention, and this is very important to understanding the ultrafiltration because of glucose and icodextrin. So what predominantly influences the ultrafiltration is hydrostatic, oncotic, and osmotic. Now, you know Starling's principle of transfer of fluids and all these. So hydrostatic pressure, you know, oncotic pressure from the predominant from albumin into the blood, and osmotic, because we are using osmotic agent to pull out drag out the fluid from the vessels into the peritoneal cavity. So these three factors, hydrostatic, oncotic, osmotic, is very important. Now osmotic we represent in milliosmos, but for simplicity's sake, what we will do is we will convert into millimeters of mercury, which represents hydrostatic pressure. So 1 milliosmos can induce 17 millimeters of mercury of hydrostatic pressure, right? So hydrostatic, oncotic, osmotic converted into hydrostatic by multiplying each milliosmos by 17 to get a millimeters of mercury. Now look at this slide. It says what determines transcapillary ultrafiltration. So there are so many factors. So don't look at this. Actually, I told you to look at this, but actually this is very complicated and nobody should focus more than a second into this slide because this is not English. What English is, average ultrafiltration is determined by all these three factors which I mentioned: hydrostatic, osmotic, and oncotic, times hydraulic conductivity, times total effective pore area. What I said is the surface area and contributory pore size. So all three: osmotic, hydrostatic, oncotic, times hydraulic conductivity and effective pore. Let me further simplify this. Forget about that slide as well. Now, key determinants of average ultrafiltration rate in PD is because of the osmotic gradient. Now remember this, we'll be talking a little more detail about this. Osmotic gradient, reflection coefficient of the osmotic agent, what we are using, and then pore areas. So these three are very important. You should remember this. So determinants are osmotic gradient, reflection coefficient, and pore areas. Easy. Now let's see reflection coefficient. So reflection coefficient for large pores for glucose and nicodextrin is 0. So large pores we do not actually talk about ultrafiltration. We talk about ultrafiltration only with respect to small pore and aquaporins. Now small pore, the reflection coefficient of glucose is lower than icodextrin. Glucose is 0.05, icodextrin is 1. So smaller the reflection coefficient, it is loosely entangled. It will allow easy transfer of glucose. So there will be gush in fluid, but it will not continue for longer period of time, right? Aquaporins, for aquaporins, the reflection coefficient of glucose and icodextrin is both 1. Then obvious question which will come to your mind is, I said earlier that icodextrin do not remove water through aquaporins. I don't know, I do not remember whether I told you at that time or not, but now I'm telling you, icodextrin doesn't help in fluid removal through aquaporins. And what is the clinical application? Since icodextrin doesn't stimulate or work through aquaporins, there will be no immediate gush of water into the peritoneal cavity. And that is the reason why icodextrin doesn't lead to sodium sieving. Now, remember sodium sieving? So sodium sieving occurs only with glucose solutions and not with icodextrin solutions. And we will see why. But you have to remember, aquaporins are not activated by icodextrin, and that is why there is no sodium sieving with icodextrin. Let's get a little more complicated here, but I would appreciate your attention here. Factors, let's forget glucose. I told you a reflection coefficient is 1 for aquaporins, and for small pores is 0.05. And a major determinant of average ultrafiltration per exchange is reflection coefficient. So what I mean by reflection coefficient is in these two slides, which determines the membrane permeability and determines the ultrafiltration. So if the reflection coefficient is high, mean reflection coefficient is high, that means the peritoneal membrane is very tight. It is not allowing the absorption of glucose or any other solute from the peritoneal cavity back into the system. So if it is tight, there will be slower glucose diffusal from peritoneal cavity. The osmotic gradient will be maintained longer, and there will be more ultrafiltration which will happen. Okay, and this happens with slow transporters, right? Those who are slow transporters have higher reflection coefficient and tighter membrane. On the contrary, those who are rapid transporters have loose membranes allows the dissipation of glucose very fast, takes away the gradient, and then that's why the ultrafiltration is lower, and that is why these are called rapid transporters. So again, remember PET, fast transporters, slow transporters. Slow transporters, tight membrane, high reflection coefficient. It may be a little difficult at this stage, but if you go through it once again, you will realize that it is very simple. So this was about glucose. Now let's discuss about icodextrin. Now, as I said, icodextrin is a glucose polymer with a molecular weight about 16,000. It is variable, but mean is 16,000. And as I said, its reflection coefficient is 1. So how do we calculate the osmotic gradient? If you remember, if I go back to my slide, you remember this, I told you the determinants are osmotic gradient, reflection coefficient. We discussed about reflection coefficient, and about pores and gradient, I'll tell you immediately. So osmotic gradient is the important factor which influences the ultrafiltration. So how do you calculate the osmotic gradient? So for example, if you take a 4.25% bag, the anhydrous glucose in that is only 3.86, and that is why some companies label it as 3.86% glucose. So 3.86 means the glucose content is 38,600 milligram per liter. Okay. When you divide with the molecular weight or osmoles, 180 is of glucose, which we know from beforehand. So osmotic gradient comes out as 214 for glucose 4.25% bags. I hope it is clear at this stage. So how you calculate osmotic gradient is the percentage of the concentration of that molecule, in this case glucose, divided by osmotic weight, which gives us the osmotic gradient. Now, what is the gradient actually is calculated by dialysate minus plasma. So this is the osmotic strength of glucose. Now gradient is D minus P. 214, what we calculated here, is the osmotic weight of glucose, 4.25%. And in blood, the glucose levels are low. Its osmotic weight is only 5. So 214 minus 5 is 209, which is the osmotic gradient for 4.25% glucose bags. So you can remember this, memorize this also, but you should know how we have derived this osmotic gradient. What about the icodextrin? The percentage of icodextrin used is 7.5%, which means 75,000 milligram per liter. We have seen the molecular weight in last slide is about mean is 16,000. When you divide, it gives a osmotic weight of 4.7. Now compare this osmotic weight of 214 of glucose and only 4.7 of icodextrin. If you calculate the gradient, since plasma doesn't contain icodextrin, 4.7 minus 0 is 4.7. So osmotic gradient of glucose is 209, and as compared to that is hardly 4.7 of icodextrin. So here you will get an explanation of working of icodextrin in both aquaporins and small pore. So for aquaporins, what happens is both glucose and icodextrin solutions used it, so you do not have to calculate. Let's straight away go to ultrafiltration of these two separately. So glucose, we discussed reflection coefficient is 1 for aquaporins. Effective gradient we calculated just now is 209 for 4.25. And what will be the osmotic pressure? Now from gradient, we have to calculate pressure. And if you recall, when I was talking about the osmotic gradient to convert into pressure, you have to multiply by 17, which equivalently gives your hydrostatic pressure. So 209 is the gradient. We multiply by 17 and convert it into osmotic pressure. This is the pressure by which the glucose sucks in fluid from the blood, which is 3,553. So huge osmotic pressure is there. And that is why even when the aquaporins are 2%, channels are 2%, because of the strong osmotic pressure, the fluid initially gushes out into the peritoneal cavity, leads to dilution of the dialysate, the sodium sieving effect, and everything. So I hope if you have understood the mechanism of calculation and all this, you will appreciate that why aquaporins are stimulated by glucose and why not. I'll show you with icodextrin. So as same thing with icodextrin, we know that osmotic gradient is 4.7. We have calculated just now. And to calculate osmotic pressure, you multiply by 17, which is 80. And 80 as compared to 3,500 is huge difference. And since the pore area of aquaporin is only 2%, this small osmotic pressure cannot excite the aquaporin, and hence icodextrin doesn't work through aquaporin. There is no water, practically there is no water transfer because of icodextrin through aquaporins, and there is no sodium sieving. So I hope it was a little complicated, but I needed to explain you because many people do not explain this, and it is very important to understand. In small pore, there is a different, I mean, gradient is same. You see 3,500 here and 80 here, but the pore size, if you recall, I told you determinants are gradient, reflection coefficient, and pore area also. Now in small pores, the area is 95%. And since icodextrin is not getting absorbed, it continues to have its impact for longer period of time to draw the ultrafiltration, as compared to glucose, which gets dissipated and it doesn't continue to have an osmotic effect for beyond 4 to 8 hours. So that I think finishes my talk, and I have a couple of questions for you to ponder. We are 45 minutes, maybe a couple of minutes more, and then we can take questions as well. So I discussed about your anatomy, physiology, their application, about sodium sieving. I discussed about the solute transfer factors affecting it, how to influence briefly, because when I talk about prescription, then probably I may talk about details about how to influence solute and fluid removal. But I did mention briefly about how to influence the solute removal. I discussed about factors influencing fluid removal. I told you in detail what is the mechanism by which icodextrin works in small pores and doesn't work in aquaporins, and what is the mechanism of sodium sieving through aquaporin because of glucose. So let's talk about two questions. So you don't have to answer online. You can just answer in your mind and check it whether it was correct or not. So a patient is admitted in pulmonary edema and multiple rapid PD exchanges with 4.25% dextrose are performed. As I mentioned earlier, if somebody gets admitted in fluid overload and you want to continue with PD, small multiple exchanges with high concentration bags are allowed, not icodextrin. So which of the following may ensue as a consequence of sodium sieving? So there are four options. Will there be hyponatremia due to rapid water transport from dialysate to plasma via aquaporins? Will there be hypernatremia due to rapid sodium entry from dialysate to plasma via the small pores? Will there be hypernatremia due to rapid water transport from plasma to dialysate via aquaporins, or hypokalemia? So hypokalemia, forget about hypokalemia. We are talking about sodium sieving. We are sticking to sodium. So number one, whether there will be hyponatremia or hypernatremia, and if there will be hypernatremia, what is the mechanism? So I think all of you will answer this question correct. The answer is C, which means there will be hypernatremia because of movement of sodium. Because of sodium sieving, water will move from the fluid compartment, from the blood into the water transport from the plasma into the dialysate. So concentration will increase in the blood. It will result into hypernatremia. I hope you all got it correct because mechanism we have already discussed. Let's come to the last question. Question 2, a patient has a 4-hour D over P creatinine of 0.88. So D over P creatinine here is very high, and I can tell you this is a high transporter, and D over D0 glucose of 0.35, which is reciprocal. So this patient is a high transporter. Okay, which of the following best describes the anticipated clinical findings using 1.5% dextrose dialysate and CAPD? So will there be a good solute clearance and good ultrafiltration, or poor solute clearance and good ultrafiltration, or poor solute clearance and poor ultrafiltration, or good solute clearance and poor ultrafiltration? So what do you expect in high transporters? You have to remember that high transporters dissipate the glucose very fast. So ultrafiltration is going to be poor. And for memory's sake, you can consider that solute transport will be better. So I think it will be good solute clearance and poor ultrafiltration. And my answer is correct. So I think I'll stop it here. I'll stop sharing this thing. And then if you have any questions, comments, or the part if you could not understand and you want me to repeat, maybe we have 10 minutes left. So do you people communicate through chat box, or you can switch on your mic and then ask clarifications or make a comment as well? Puneet?
Yes, sir.
Yeah, so how do you proceed? Because it's the first time I'm talking to them.
So both the ways, as the students are comfortable, the chat box also, or they can ask direct questions.
Yeah, there is something which has come up in
Yes,
chat
sir.
box.
Yes, sir.
Let me understood sodium sieving for the okay. Thank you so much for understanding that. It is a little difficult part in one class. Maybe sometimes it becomes a little too complicated, but I tried my best to go slow. But yes, this is a concept which everyone should understand. Yeah. Anyone else wants to ask any question, clarification? I hope you understand why icodextrin doesn't work through aquaporins and doesn't lead to sodium sieving. So there is another question. Any criteria of fluid selection in acute kidney injury in pediatric age group? So fluid selection, see, again, I'll go to the basics. So solute clearance is not very different when you increase the concentration of bags. So 1.5, 2.5, 4.25 and icodextrin. There is not a huge difference. There is definitely some difference, and predominantly that is because of the ultrafiltration achieved because of higher concentration. You have to understand. So when we calculate the solute clearance in peritoneal dialysis, it depends upon the total volume of dialysate which has come out. For example, if you have used 6 liters and including ultrafiltration, you have received 7 liters of fluid, the concentration is based on 7 liters, right? So the larger the volume which comes out determines the solute. So whatever difference in solute occurs, it is not because of the increasing concentration of bags, it is because of the ultrafiltration. So if you are focusing on solute removal, don't focus on concentration of bags. Concentration of bags determines only ultrafiltration. So when you pick up whether it is for acute kidney injury or chronic kidney disease, for pediatric age group or for adult age group, you have to select bags depending upon their fluid removal requirement initially. So somebody who is, for example, proteinuria, who has got a proteinuric CKD, so obviously they have more fluid overload. You know that clinically, somebody who's diabetic nephropathy versus chronic tubular interstitial nephritis. The diabetic nephropathy is more fluid overloaded. They have got more edema. And tubular interstitial nephritis has lower edema. So you will have to select fluid depending upon fluid removal. And as I said, see, it's a very interesting, and there are so many other factors which I want to tell, but time is limited. If you can ask uh, for a PD prescription class, maybe we'll discuss this later on. There are some more comments which is coming up on the chat box. So PD prescription, when I can discuss how to select what kind of fluid you want to initiate and how to change it over a period of time. Could you please comment on how can we do PD if we do not have a company made PD solution? Oh, so customize. So yes, you can customize it. It's not that you cannot do it, but then in present scenario, present era, I would rather uh, not motivate you to do it, because when you customize it, there are always chances that there might be introduction of infection in the bags. So because you have to make it compatible so that exchanges can occur, sodium, potassium, magnesium, calcium, and all these things. If you start injecting in any, for example, any solution, for example, in glucose solution or normal saline solution or ringer lactate solution, the changeover of peritoneal dialysis over decades is because of the connectology or connectivity. Here, you do not have to do any spikes. Device system, you do not have to do any spikes. And if you start injecting all these materials into the fluid to make it conventional, I would rather not suggest you, except in extreme circumstances. You are in periphery and you have got nothing else there, and there is an emergency and you have to do it, then you can customize it. You know the constitution of PD dialysate, and you can customize it. There is no harm in doing it, right? So I had a slide of composition of glucose-based dialysate solution, and I could explain. Unfortunately, because of time constraint, I removed it. Maybe when we discuss about prescription, I can show that, and you have to accordingly customize either on normal, either ringer lactate, normal saline, or glucose-based solutions. So I hope that answers your question. Anyone else? Otherwise, we call it Puneet.
Yes, sir. Thank you so much.
Thank you so much. Let me thank all the students. I hope that I was clear in the concept. Otherwise, I mean, I can come back on this topic again. And then I wish all of you keep safe from the second wave of Corona. All the best.
Thank you, sir. And sir, hopefully we can share the recording with the other students.
Yes, session? Sure.
Yes, sir. Sure, sir. Sure, thank you so much.
If the recordings are there, I was not aware, then you can share with all the students as well if they want to go back into the slides and lectures.
Yes, sir. Thank you so much, sir. Thank you.
Thank you so much. Bye. Take care.